Hello, everyone, and welcome to our webinar, Approaching End of Life Signs and Symptoms. My name is Lauren King, and I'm the Community Education and Caregiver Academy Manager at Coastal Hospice. Welcome to our Caregiver Academy. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Hartley Nursing and Rehab, Atlantic General Hospital, Montgomery Hospice, Riverside Home Health and Hospice, Berlin Nursing and Rehab, Tidal Health, Chesapeake Healthcare, and many more. It's wonderful to see everyone today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to address to help with any technical issues. I want to thank you for your patience ahead of time, should we have any. Also, I'll come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Our webinar today will be moderated by Lauren Blair, Community Relations and Development Manager and Caregiver Academy Moderator at Coastal Hospice. Lauren has more than 18 years of experience in the healthcare field. She holds a master's degree in social work from Salisbury University, is a licensed master social worker in the state of Maryland, and a licensed clinical social worker in the state of Delaware. Lauren serves on the board of directors at the Gray Center of Maternal and Women's Health, is a subject matter expert for the Dementia Care Resource Initiative through the National Partnership for a Healthcare and Hospice Innovation, and a nominee of the 2023 Women to Watch of the Chesapeake. Lauren, I'll hand it off to you.
Thank you for that introduction, Lauren. I'm pleased to welcome our interim president and CEO, Ann Lovely, here today. Before I introduce her, I will share with you the disclosures for those of you receiving continuing education credits. For physicians, this activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accredited Council for Continuing Medical Education through the joint providership of Tidal Health Peninsula Regional and Coastal Hospice. Tidal Health Peninsula Regional is accredited by MedG, the Maryland State Medical Society, to provide continuing medical education for physicians. The Continuing Medical Education Committee of Tidal Health Peninsula Regional designates this activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurated with the extent of their participation in the activity. The planners, speakers, and the Continuing Medical Education Committee of this educational activity declare that they have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. For nurses, Tidal Health is an approved provider of nursing continuing professional development by the Maryland Nurses Association and accredited approver by the American Nurse Credentialing Centers Commission on Accreditation. In order to receive contact hours provided by Tidal Health, you will need to attend the entire course, missing no more than 10 minutes, and complete the following course evaluation with post-test. The speaker presenting today does not have anything to promote or to say that she is dealing with in a financial way. Please miss no more than 10 minutes and complete the following course evaluation with post-test. The speaker presenting today does not have any financial disclosures. And for social workers, Tidal Health Peninsula Regional is authorized by the Board of Social Work Examiners in Maryland to sponsor social work, continuing education, learning activities, and maintains full responsibility for this program. This training qualifies for one Category 1 continuing education unit. We are very excited to have Ann Lovely here with us today. Ann Lovely, RN, BSN, CHPN, joined Coastal Hospice in March 1999 as a certified nursing assistant. While working at Coastal Hospice, Ann advanced her education, becoming a registered nurse working as a case manager for many years while mentoring many employees and students. Ann has a wealth of experience in hospice and became the education coordinator in 2017. Ann assumed administrative roles of increasing responsibility, including serving as Director of Quality Improvement and Performance Improvement and Chief Clinical Officer prior to being appointed as Interim President and CEO. Welcome, Ann. We're so happy to have you here with us today.
Thank you, Lauren. I'm excited to be able to talk to everyone about hospice care and really looking forward to giving a better insight on end-of-life care.
Wonderful, wonderful. So tell me, Ann, what are we going to be discussing here today?
So I want to give everyone just a better understanding of all of hospice care. Also want to talk about some of the signs and symptoms that you may see at end of life, and also how we could educate families and patients about the dying process. But another one of my objectives today is we have so many people that can offer, can refer hospice care to folks. I want them to understand when maybe is a better time to refer patients to hospice services so that we're not getting patients so close to the end of life.
And for those of us who may not be familiar with hospice, tell us, Ann, what is hospice care?
So the one thing that we need to remember about hospice care is quality rather than quantity. So sometimes with hospice care, we may not, we may have people that are receiving some type of treatment, but it may be causing them more harm. Sometimes stopping that may lessen the time that they have, but we want to give people better quality of care. We also want to think about comfort rather than curative. And, that is the thing that we want to make sure that we get across to folks, that we can make them more comfortable at the end of life sometime than what they're experiencing elsewhere. And that we don't want to give them things that are going to cause them more harm. We want to allow death to happen naturally and allow them to set out their goals of care. And we want to focus that care on their goals. And also, cancer is not the only way that you get into hospice care. We have our own lung program. We have heart patients as well. We have a cardiac program. So we have many more reasons why patients come on to hospice care now than just cancer. And also, I kind of want to break that myth that if someone is a full code that they can't come on to hospice care, because our goal is to help teach the patients and the families and to kind of get them where they can make better informed decisions about their end of life care.
Absolutely. I'm glad that you're going to be dispelling some of these myths today, because those are ones that we hear often about, they have to have cancer, they have to be a DNR, or people will say, you have to be bedbound to be on hospice or only a few days left. So we're going to get more into that nitty gritty today, and I'm excited to do that. So how does someone qualify for hospice, Ann?
So to qualify, and what I'm going to be talking mostly about today is qualifying with Medicare hospice, with the Medicare hospice benefit, and that's your Part A. And to qualify, you would need to have a physician, the hospice doctor or your community physician, certify that the person has a terminal illness that is 6 months or less. But Medicare goes on to say also, if the disease follows its normal progression, that meaning that, at 6 months and 1 day, we're not going to discharge because you're no longer eligible, but you do need to show a steady decline. To also be eligible for hospice care, you need to be accepting comfort care instead of curative care, because that's Medicare wouldn't pay for both. And also you would be needing to choose that to elect your benefit for Medicare.
So now that we know about what the requirements are, let's talk about what the hospice benefit actually covers.
So when someone comes on to hospice services, one of the things that folks don't remember is that you can keep your community physician. You do not need to give up that community physician and only be followed by hospice services. We actually like it when our patients continue with their community physicians because it allows us to have a little more of a background on that patient's care. But you would receive, a physician would be overseeing your case. You would also be receiving nursing care, and that nursing care needs to be at least every 14 days by Medicare requirements. But we like to see our patients a little more frequent because it allows us to keep a better eye on their care. So if there is a decline, that we can see that. Hospice also will cover durable medical equipment, that's DME. So that may be something like if you needed a wheelchair or a hospital bed, we would help with that. But we also help with other medical supplies such as bandages, catheters, or anything else needed to take care of you. And one of the other benefits that folks like are the medications that are related to your hospice diagnosis. They're covered. So if the patient is experiencing pain or any other type of symptom management, any of the medications or treatments to help with those symptom managements, they would be covered. We also have certified nursing assistants that can go out to the home. They can do anything from providing, bathing, or just to be there for safety if the patient's still able to do that on their own. And also social services. Our social workers are a wealth of reference, and knowledge, and they can help you with the community resources that you need, as well as we have spiritual and grief counseling for families. It is spiritual counseling, not necessarily religious, unless that's what you're asking for. And we also have inpatient respite care. And I'm going to talk about it a little bit more, but the inpatient respite care allows for our caregivers to have a break. And then we have volunteers that here at Coastal Hospice, they do anything from, we have a wonderful woman who grows flowers for our patients and puts them in vases, and we deliver them out to them, to people who are doing bedside respite with patients, or even working here in our office. And we also have music therapists. And I often tell the story about music therapy where I've seen people that are nonverbal, and they go in for they're receiving music therapy, and all of a sudden you hear them singing along to their favorite hymn. It's a joy to watch.
Absolutely. I was just talking about our music therapy in that regard last week too, to
Yeah,
someone in the community, because it's so, if you've never seen something like that, it's really amazing.
yeah, it really is awesome.
So many incredible benefits that is covered under the hospice benefit. Thank you.
Right, right.
Well, how about the levels of care in hospice that we see?
So we do have 4 levels of care. One of the most common one is the routine home care, and these are routine home care is basically where the patient is calling home. So we would visit the patient at their residence, their private residence, nursing home, or even assisted living. And we do have some routine home care in our facilities, but routine home care is wherever the patient calls home. And we've even had homeless patients, so wherever we can meet their needs. Also, we have respite care, and I was talking about this earlier. It is the benefit of giving the caregiver a 5 overnight respite, a break. And this allows the patient to go to one of our facilities, either at Coastal Hospice at the Lake, or the Mackey and Pam Stansel House, to have 5 overnights where we kind of spoil their loved one, and give them a break, and then they can return home after that stay. And if we are full at our facilities, we do have contracts with community nursing homes, some that are joining us today, where we offer respite stays. We also have general inpatient, and general inpatient is kind of that short-term crisis. So it's someone who perhaps is having symptoms, and we're unable to control them in the home setting, and we will send them to one of our facilities to work through that symptom, get them better controlled, and our goal is always to send them back home with their loved ones. But we also have continuous care, also known as crisis care. And this is a benefit where nursing staff, and sometimes aides as well, will go to the patient's home, and they will offer care a minimum of 8 hours at a time. And this care is for someone who is in crisis. So maybe it's someone who doesn't necessarily need to go to Coastal Hospice at the Lake or to the Stansel House, or maybe it's something that we can control with medication, get them better controlled, and then resume with normal care.
So many different options based on the patient's needs and where they are.
Right.
There's we're definitely dispelling a lot more myths, because
Yeah,
one thing I always hear from the community is, "Oh, I don't want to go anywhere. I don't want to go to hospice." But really, in
right.
actuality,
Yeah.
most of the people,
Hospice isn't a place. It's
yeah,
it's
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 not a
a
place. We have
right,
some places, but most are right in their homes, which is awesome.
right, right.
I do have a question from the audience. Gloria asks, do patients ever come off of hospice once they come on your care, or do patients always stay to the end?
So we do have patients that what we call graduate. So, I was talking earlier about our cardiac program. So sometimes there are patients that come to us. Maybe their medications weren't being managed. Maybe they had a whole lot of medications. Or their symptoms weren't being treated, and they have someone who's watching them and getting those medications better controlled, and they do better, and that's a good thing. Sometimes they're sad to lose us, but it's a good thing because we do get about 1% of our population graduate. And another way that someone can actually come off of hospice is if they choose to. You have the right to revoke your benefit at any time. Um, I'm
And,
sorry.
and can they come? I'm sorry. Can they come back on if they decide, oh, you know what? I do think I want hospice
They
now.
sure can. They sure
Wonderful.
can.
Wonderful. I have another question from the audience. Lisa asks, how is continuous care / crisis care paid for?
So that's actually also part of your Medicare benefit. Yeah,
Yeah, it's amazing.
that's great.
I don't, yeah, it's hard to, it's great, all the things that the hospice benefit includes and that the Medicare benefit actually pays for, and they're so, underutilized, like the respite care. I was talking to a lady in the community a couple months ago, and she said, I would not have been able to go to my son's wedding if it hadn't been for respite care, because I wouldn't be
That's
able
so
to pay
true.
for my mom to go stay
Yeah,
somewhere while I was gone. And she said, and I called the facility probably 8 or 9 times a day to check on her, because her mom was her life and she took such
right,
good care of her. She said, and everyone was so kind about just letting me know how she was, and she did great. So there's lots of services that are Medicare and that our hospice benefits pay for, that we can utilize for our patients.
right.
Awesome questions. Thank you for that. And yeah, just a reminder, please keep putting questions in the chat box. We love to answer them, and it helps us to know what it is that we can help serve the community in knowing. We're going to move into a little different topic. Let's talk about death and dying.
So just kind of want to ask the audience, what is your comfort level talking to patients about death and dying?
Then Allie put a little poll up for us. You can tell us, are you comfortable? Are you neutral? Are you not at all?
It can be a little challenging sometimes, but I kind of hope to be able to give you a little bit more information.
Absolutely. And we'll see the poll answers shortly. Here we go. All
Very
right.
good.
Yeah, so 65% say they're comfortable. That's great. That's
That
great.
is good.
Yeah. 24% say neutral, and then 11% say not at all. So
Very
this is
good.
great. Yep, we're going to help you, like Ann said, hopefully feel a little bit more comfortable. Maggie says from the chat, I think my answer stems from the knowledge. New to hospice, so just getting knowledge about how to start this conversation. That's
Right.
great. That's great, Maggie.
Right.
Great. Wonderful. Let's dig deeper into what we might see when someone is getting closer to death.
So, to be quite honest, when I was starting the conversation, I was talking about wanting to get earlier referrals. So, really, those conversations would want to be had, prior to someone going to the hospital. Maybe the primary physician should be talking about hospice or end of life goals. So, when I want you to be able to see these so that you can see the transition phase of the dying process is a little earlier on, yes, but we want to be able to have time with our families, time with our patients, so that we can have these, to teach them more about. So let's go ahead and go to the transition. So there are two phases to the dying process. The first transition phase is at about 2 weeks on average. It can be a little longer. And we also have the active dying phase that can last about 3 days, sometimes shorter. Not everyone is textbook, and sometimes it can happen all at once. But the exception to the rule is that we usually see these signs. And I didn't want you guys to think that, everyone is the same. So generally, the dying process can take weeks to hours.
Gotcha. Tell us what signs that we might expect during the transitional phase of dying.
So during the transitional phase of dying, you're going to notice that I talk about this often when I even teach this to families. I talk about that this is the most hard for family members to see, the decrease in intake of foods and liquids, because we're of a we are of a culture that we want to feed you to make you feel better. So it's a little harder, but the body just really isn't requiring as much food, for they're not using as much energy. I can remember one of my coworkers, she used to do a similar presentation with me about this, and she was saying that she had an uncle who was a prisoner of war, and he said when he was in the transitional phase, I know hunger and I don't feel hungry, so they're just not needing it. But it is hard for us as caregivers to see them losing weight and not wanting the food. But also they are more easily fatigued, and they may start having, have muscle wasting and weakening. So you may have to assist them more with activities of daily living and just regular routine activities. So one of the things that I try to remember to teach nurses, especially new nurses that are new to hospice, is remember that caregiver may not have been the one that used to take their blood sugars. So you may need to teach them because they may not be able to do it anymore, or maybe they had a feeding tube or something that the patient was able to do on their own. You might need to teach that family that when they start to get more fatigued and have more weakening. Yeah.
I do have a question from the chat box. Lindsay asks, do you have suggestions to help explain the conversation to children if it is a parent or grandparent who has cared for the child? Lindsay, this is a great question, and we actually have heard this question asked to us so much lately that we have set a webinar for November, actually, for during Hospice Month. It's called Supporting the Grieving Child. It's going to be on November 13th, and we'll send you more information about that. But there's been so many things lately that have prompted this next webinar for us. So yes, you're so welcome, Lindsay. It's going to be a great one. I don't want to go too much into it because it's our next one. I don't want to take too much time, but it's our director of bereavement and spiritual care is going to lead that with his wife, who's actually a clinical therapist too. So it's good. Tune in for that one, Lindsay. I'm going to make sure you have information on that.
Very good.
Great. All right, let's go into some more signs of the transitional phase.
Some other things you may notice are they may kind of have some unfinished business. They may be you may need to actually help them tie up any loose ends that may have. I've seen things as little as wanting to speak to someone or wanting to finish up a garden. You just really never know, but you may have a patient that has they feel like that they need to kind of finish up. We also do a lot of life reviewing at this time, just for that purpose. But physically, you may see some increased swelling. It may be to the whole body, it may be to extremities. So we want to make sure that we're monitoring for that often so that we can relieve and make sure that they are comfortable. They may not be able to, because they do have less intake, they may not have as much protein intake. So it may be a little harder for them to heal wounds that they may have. They may have increased infection or be at risk for increased infection. But we also, with that, because they're not going to be eating as much, we're going to be wanting to watch their skin and make sure that that they're safe and not receiving any additional pressure sores or anything. You may also have someone in the transitional phase that's talking about people that he either have passed or that we can't see. And I see that there's a lot of social workers, and I never tell them that it's not true or that I can't see them. I always would say things like, tell me more or try to figure out. But sometimes when you're that caregiver and you really can't figure it out, I would often suggest to write down what they're saying, because later when you're not as stressed, you might be able to figure out who they were talking to or what they were talking about. You may also hear your loved one or your patient talk about going home or taking a rest. And our medical director calls this journey talk. Sometimes they know before we know, and they may talk about that they want to leave or I'm going home. And I swear they really know. They do have an idea. But also you may have someone who talks about reverting to they may have reverted to their primary language. So it may have been that they just kind of go back, and you may need a interpreter when it comes to that stage.
I like your idea of writing things down just
Yeah.
so you don't forget, because it's a
Yeah. I've actually done that for myself in my
Yeah.
own personal, and it really worked out. We were able to think about it later on.
wow. That's
Yeah.
great. I see a hand raised in the audience. Andrea, feel free to type in your question, or if you would like, we can unmute you for sure, and you can ask. While we're waiting for Andrea, let's move into the signs of the transitional phase. The signs of the withdrawal. I'm sorry.
So one of the other things that happens in the transitional phase is that people will just kind of start to withdraw. It's part of the process. I often wonder if it's to kind of protect us who are being left behind. But they will sometimes have decreased attention span. Things that they used to enjoy, they may no longer be able to. It may be that every day they got up, got coffee, sat there, watched the news, and they just aren't showing interest in that anymore. Is it the fatigue? What is it? But you often will see it. They may require more sleep. Or when they are sleeping, you may notice that it's a little more difficult for them to respond or to arouse. So that is something. But they may withdraw from seeing visitors. I've often come to patients' homes and seen signs on the doors about not wanting visitors, and they'll sign, per hospice. But whatever the patient needs, we are in agreement with. But also, as I mentioned earlier, this is the really good time for life review. Continue to talk to the patient as much as they allow, because the time is getting near.
Mhm. How about the restlessness that we might see?
So the restlessness, it often is associated with confusion and sometimes agitation. It is, they want to get up. Is it part of that I need to leave feeling? Is it also maybe associated with their having I don't want to call them hallucinations. I guess that's what it is, but visions of people from the past. Is it that they're trying to join them? But either way, sometimes it can become difficult. Now, if there are medications that we can give patients if we need to kind of relax them a little more so they're not as restless. But it is something that we often do see at the end of life. They may be picking at their clothing, or just kind of squirming a little bit. It varies, the restlessness.
Let's talk about pain concerns. Pain can be something I know that really concerns people when we talk about death and dying.
So sometimes people who never experience pain could have pain at the end of life because maybe they were, they're in bed more, they were used to being active. But what we like to do is we like to make sure that our patients that are experiencing pain are getting pain control around the clock. We want to make sure that they are able to get they're not having that wax and wane. We want to make sure that it's pretty even keel, good control. We want to treat them with a long acting. And if a patient is beginning to experience pain in between, we would want to make sure that we are treating that as well. And Dr. Juarez, our medical director, has a rule of like 3 or more breakthroughs a day. We may want to consider increasing that long-term medication. But there are other things that we can think about to do for pain control other than just medications. And that is, we could do breathing exercises, guided imagery, distractions. Sometimes us visiting the patient or, anyone visiting the patient is a distraction. They sometimes can, just sitting down beside them, having a conversation, massage if that makes them comfortable. Visits with maybe one of our counselors to also, assist, but not forgetting about the little things such as heat and cold and even prayer that may help with our spiritual counselors visiting as well.
I think it's helpful to hear these non-pharmacological
That's
approaches
right.
as well.
Right. Don't just go for the medications.
Yeah, yeah. There's so many other things that we can do with hospice.
Right.
What signs and symptoms of pain might we see?
So sometimes people can tell us what's going on with their pain, but one of the things that I want to make sure that to let you know is sometimes people are embarrassed or ashamed to say that they're actually having pain. So you may want to refer to it as different terms. So you may want to ask if they're having any aches or pains, or I've even had someone call it owies. Because sometimes they think it's a weakness to have pain. You may want to also look for any kind of facial grimacing, guarding, any kind of groaning, crying. Don't assume that it's related to sadness. Is it pain? But also they may be agitated or restless or shuffling. And if someone's telling you that they're having pain, actually look at the pain, look at the area. Don't just ask them where it is. Because it could be maybe that they're starting to get a bed sore that they weren't, that they didn't have before.
Sure. Yeah, that's a very good point. So why might patients be at risk for the lack of treatment of pain?
So there's all kinds of reasons. One of the reasons are patients who are older may not be able to, may no longer be able to tell you. And the same thing for people who are younger. It's the next slide, please. People that are younger as well may not be able to tell. Also, there's fear of addiction. And there's fear of medications out there for everyone. Just remembering that it's a physical need is very important. We do sometimes have patients that don't like to take medications because they fear constipation. And for any patient that we have on pain medication, we automatically would start them on a bowel regimen as well. but also fear of sedation. Maybe they want to be more awake. But if you have a patient that is expressing that to you, I would kind of talk to the physician more about perhaps, offering something else. I talked about nonverbal, but also someone who is unable to speak your language. You want to make sure that you are getting an interpreter to make sure that they are pain-free. And in this day of time, we do have patients that do have histories of addiction or are suffering through addiction. And you want to make sure that you're really talking about what works for them and what they're on. And they may require more medication. So don't always assume that they're maybe seeking more or higher doses. They actually do require more dosing, higher dosing to control their symptoms.
Sure. It's helpful to know. It's helpful to think about all of the things that we can look for, both non-verbally and what we need to look for as far as people getting lockup treatment.
That's true. Very true.
This was a very eye-opening look at the transition phase. Let's move on to the active dying phase.
So, as we said earlier, the active dying phase is usually about 3 days. It can be a little bit longer, but not usually. And usually when the patient is at this stage, they're kind of in a coma-like state. They're difficult to arouse, and they're unresponsive. This could be when patients become a little more agitated. So maybe if someone was having hallucinations earlier in the transition phase and didn't really require medication or treatment for that, they may need it at this stage. But it's not usually their normal personality. It's just kind of this part of the dying process.
Sure. How about breathing changes that we might see?
Breathing changes are the thing that I usually talk the most about at the end of life. It can be pretty scary because your loved one can go from normal breathing to all of a sudden stopping. They'll have apnea, and then they'll, start breathing again. And when you're there, visual, by their bedside, and you see that, sometimes it can be frightening. So that's one of the first things that I would talk about when someone is starting the dying process. But another thing that you may see is a breathing pattern change. So breathing, where someone may have apnea and then all of a sudden they have that increased respiratory rate, and it kind of looks like hyperventilating a little bit. And sometimes we do have patients that then kind of have that we call like a guppy breathing, fish out of water breathing. So I talk about that. And sometimes loved ones are a little concerned about this, and they ask about oxygen and point in this kind of time, but not always does oxygen help for a patient that's going through this. It's just kind of part of the process. But informing your patients, letting them know what they may see, the caregivers, it's much more appreciated because this is it's difficult to see.
Absolutely. Absolutely. I'm so glad that you emphasize the importance of, talking to the caregivers about what they're going to see and kind of, warning them about this natural process. It's
Absolutely.
helpful. What other breathing changes might we see?
So because you may also see that a patient will have the inability to swallow. So that's when it's no longer safe to attempt to give the patient food.
Mhm.
We would want to make sure that we are keeping the mouth moist by using touthettes. Um, Not really trying to give them food because they're not awake and alert enough, and it could cause them to actually aspirate and it go into their lungs. So that is something that you will see. But also, what is a little difficult is also when they begin to have those breathing changes, you may also begin to hear the oral secretions in the throat, also known as the death rattle. We don't like to call it that, but it's something that they may hear. We do sometimes have medications that help with that right away, but sometimes those medications don't work. We do, we alternate how we have the person in bed. We reposition them to see if that helps. But it is more bothersome to us to hear. It does not generally look as though it is causing discomfort to the patient.
That was going to be my question. Is it more uncomfortable for us to see?
Absolutely. And hear, yeah.
Sure. Let's move on. I know we talked a little bit about the about feeding and eating towards the end of life. How about artificial nutrition and hydration?
So, as I was saying, this is one of the most difficult things that families that and when their loved one is sleeping more is pretty hard. But patients and families are able to make choices, but we want to give people an idea about artificial nutrition and hydration, and not always is it the best, but it can sometimes continue to cause problems because the patient isn't absorbing like they used to. So that does put them at a higher risk for aspiration, and it actually could speed up death. So not always, and it doesn't prolong life, and it could create a more uncomfortable end of life. They say dehydration isn't painful, and it actually can help. Where hydration, artificial hydration, can prolong and be more painful. So we want to kind of think about that when we're teaching folks about end of life decisions. But if you're receiving these, it's not what's going to help your mouth and stay moist. It's going to be providing mouth care and keeping on top of that. So, but this is a hard topic sometimes to talk about. And I kind of talk about that person who's receiving IV hydration in the hospital, and you see them kind of fill up with fluid. I kind of talk about that with families and patients. So.
That's helpful. You're right. It is a very difficult topic to talk about, but these are helpful kind of information as we share these with our patients.
Right.
How about extremity changes?
So sometimes with extremities, just overall, a patient who sometimes may have been cold all of the time may not be as much anymore, or vice versa. They may be warm, and they're usually cold all the time. So that's one of the things that you want to make sure that you're checking when you're caring for someone. But the other thing you may see is you may notice that they may become cyanotic or have like a bluish tinge. It may be on the arms, the legs. You may even notice it around the lips. And sometimes this is beneficial to have oxygen, but not always does this help, especially when they're experiencing modeling. You won't always see that oxygen is assisting for this, but they will be very cold to touch, usually when this is happening.
How about let's move into changes in vital signs that we would see?
So some of the things that we've noticed is folks aren't able to regulate their body temperature anymore. So I was saying earlier, some people may have they may experience that they're cold and they're usually hot all the time, or vice versa. And it's usually because they're just not able to regulate their own body temperature anymore. So you want to make sure that you're taking, that you're watching out for that. And it may be something as simple as removing a blanket, maybe draping it over the hospital bed instead of having them tucked in tightly. Not always do we need to go right for medications. Like I said, a cool fan, a fan just kind of blowing in the room sometimes can help cool off your loved one. So It's not always medication that you need, but you also may notice that, their skin is cool and clammy. So you may want to keep an eye on that. But vital signs can kind of go all over the place. We do check them usually at the end of life. If it makes someone more uncomfortable to take their blood pressure, we may not. But they can be, all over the place. Sometimes the heart rate, it can be a lot faster than normal. And that is probably part of the dehydration part and part of the dying process as well. Or it could go lower just because the heart's not pumping as fast. So it can kind of go all over.
Varies.
Mhm.
How about what changes in output might we see?
So we do see changes in urinary output. Um, their kidneys aren't working as well, so you may notice that they also may have darker urine. Is that muscle wasting? Is that from dehydration? But you're not going to see as much urinary output. Nurses will be checking this just to make sure that it's not that the patient is unable to go. Sometimes patients do have to get a Foley catheter at the end of life just for comfort measures to make sure that they're able to go. But also, we want to make sure that they continue to have bowel movements regular, but they may become incontinent. Where they weren't before. So again, part of this caregiver teaching is anticipating that this is going to happen. So you may want to teach them about urinary and bowel incontinence and how to change their loved one and how to protect bedding and all that. But these are some of the changes that you may see in their output. But we don't just let the patient go without a bowel movement because they're kind of getting to the end stage. Because sometimes if they're not having a bowel movement or not able to urinate, that can be what's causing them to be more restless. So we want to make sure that we're treating that symptom.
That makes sense. It's part of keeping them comfortable and
Right. Right.
How about that surge of energy that we may have heard about?
So that surge of energy or burst of energy that you sometimes hear about, we sometimes see that just as it can be very subtle, or it can be very, I mean, you really notice that it's happening. And I kind of talk about this with patients and caregivers because it could be that they've had their eyes closed in that coma-like state, and they just kind of open their eyes and you can tell that they're really looking at you. Or maybe they wake up and ask for food and they hadn't asked for it for days. So it can vary to the extreme. And sometimes it's heartwarming to kind of see that last. But they may be able to have conversations with you. You just really don't know what's going to happen. But it's kind of like their last little gift to us.
Absolutely. That is
Yes.
such a gift. And that's maybe a good time too to get out your notebook and jot down some.
Yeah, it is. It really is. Yeah.
So, Anne, what happens when a loved one calls Coastal Hospice and says, I think my loved one has passed away? What do we tell them to look for?
Right. So one of the disadvantages of us not, being there all of the time with the family is that sometimes, families call us to say, I think they've passed away.
Mhm.
So, one of the things that they're going to notice about their loved one is that they no longer are going to have respirations, and they won't, they no longer will have a pulse. And we will notice that their eyelids are open, or their pupils may even be fixed. And sometimes what happens when a patient has passed is that their jaw may kind of relax and kind of stay in a position where their mouth is kind of open. And they may start to notice that their body becomes a little more rigid. But know that nurse presence is on its way. Just give us a call. We would like to be there with families, but sometimes this happens when we're not there. And we encourage folks to call family to come and visit And then we help you by calling the funeral home, and offer that support. And our funeral homes in our community are just the best to our caregivers when their loved one has passed away. It's truly heartwarming to see. It really
Absolutely.
is.
Absolutely. And how we all work together so well.
Right, right.
This is a difficult topic to discuss, I know, but it is comforting to know that there is support available, not only before death, but also after death. So we're going to talk a little bit about the amazing bereavement support and aftercare that we have. We provide free grief support to anyone in the community, whether or not they've had any sort of affiliation with hospice. So whether or not someone is needing to someone's loved one passed away while they're under our care, or if they passed away unexpectedly or anything, we provide that free grief support. We do a variety of things. We have our memorial gatherings. You'll see one of our flyers for that. We host them in all 4 of the counties we serve: Wycomico, Worcester, Somerset, and Dorchester. We have various support groups that we hold in all 4 counties as well. And we do one-on-one support and counseling with the community members. So we're happy to help in any way. When we do have a loved one, when we do have a patient pass away under services, we provide care and support for those loved ones for at least 13 months. And we do that because it's a time that we can hit all those first, that first anniversary of their passing, or that first holiday that's going to be really hard to be, without that loved one. So there's lots of amazing things that we're able to do with our bereavement support and aftercare. And I'm happy you can go to our website and learn more about that. I do have a question from the audience I want to address. Crystal asks, how is Coastal Hospice utilizing end-of-life doulas now?
So our end-of-life doula is currently assisting with end-of-life decision making and helping with advanced directives. We will begin, our palliative home program beginning next month, and our goal for her is to be going out to visit with loved ones and assisting with telehealth visits and checking in with patients. But we will also be utilizing them in the future at the end of life to be there with patients and families.
Yes.
Thank you, Crystal, for that. The other thing that I wanted to talk about with our bereavement support is I do know we have some facilities present. We also provide bereavement support to the facilities, and we can offer gatherings for patients that you've lost as well. But having patients that have shared a room and are right there, we offer support to roommates of patients who have been on hospice care. So also think about us with that as well.
Absolutely. That's a great point, Ann. Anything that we can do to help, we're happy to do, and that we've done a variety of things in the facilities, and we're always willing to hear any other ideas that you've had too. But we love to support your staff and your team and your patients in any way.
Absolutely.
And Terry asks, is bereavement support available throughout Maryland? So we do serve the 4 lower counties, Terry. So Wycomico, Somerset, Dorchester, and Worcester counties that we support. Certainly, if someone is wanting to come to a Worcester support group and they live, in Fenwick or something, they can pop on over. That's not,
Right. And the other thing that we would do is,
I wouldn't
I'm sorry.
imagine someone would want to come from far away.
Right.
We do great.
The other thing,
Go ahead.
I'm sorry. The other thing that we sometimes do is if it's a caregiver or a patient who is providing, whose loved one is from out of the area, we sometimes connect them with hospices and bereavement support in their area as well. Yeah.
That's a great point. Yes, absolutely. That's been great. As we wrap up today, I do want to ask Ann to share with us a beautiful quote.
So Dame Cicely Saunders was she's the one who brought modern hospice to the United States, and she said, how people die remains in the memories of those who lived on, and that's why we always want to do it right.
Absolutely. Absolutely. Amazing. Let's get into some follow-up questions for the audience that we can all review together. The first one is what types of patients are at risk for lack of treatment for their end of life symptoms? A is patients with addiction issues, B, unresponsive patients, C, older adults, or D, all of the above. And
The answer would be
what's our
all of the
answer?
above.
Yes, yes. And number two, what signs of withdrawal might be observed in a patient entering the transitional phase? If we want to move to the next slide, we'll have question number two. What signs of withdrawal may be observed in a patient entering the transitional phase? A, no longer reading the newspaper. B, sleeping more. C, no longer participating in conversations. Or D, all of the above.
And the answer again would be all of the above.
The above, all the above. And finally, our third question for today, what are the eligibility requirements for a patient to receive hospice services? We can move to the next slide. Question number three, what are the eligibility requirements for a patient to receive hospice services? A, patient chooses not to seek curative care. B, patient elects their Medicare hospice benefit. C, physician certifies the patient's life expectancy is 6 months or less if the disease follows the normal progression. Oh, we have Mary. Mary comes from the chat, says D, and Judith says D.
Thank you, everyone. You see how I made it easy for you.
Yeah. Yes.
All of the above.
You did. You did. Well, I hope that everyone has learned some things today. This was very informative, a lot of information. We're going to be sending out some follow-up information to you. And this presentation was so helpful and so informative. And I just want to thank you for being here with us today.
Well, thank you for having me.
Lauren, I turn it over to you.
Thank you so much, Lauren, and thank you, Ann Lovely, for this presentation on a topic that may be relevant to many. And thank you for everyone who has joined us today. We hope the information was useful to you. We encourage everyone to attend our next webinar on Wednesday, November 13th at 12. The topic is how to support a grieving child. Please visit our website soon to register. To wrap things up, we ask that you take a couple of minutes to fill out this short survey. By filling out this survey, you will allow us to provide your continuing education credits to you via email, and your feedback will help us bring relevant programs to you, your practice, and those you care for. To complete the survey, visit the chat box. You will need to click on the appropriate link for your field or scan the QR code on the screen now. You will be able to print your certificate of completion immediately after completing the survey. Additionally, you will receive a follow-up email within an hour containing the links to the surveys. Please remember that you will need to fill out the survey within 24 to 48 hours in order to receive the continuing education credits. Also, I want to remind everyone that the certificate is presented via a link from the SurveyMonkey. The certificate will not be an email attachment. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you could call us at any time on the number on your screen. Thank you once again for joining us. I am Lauren King, and have a wonderful rest of your day.
Thank you, everyone.
Thank you.
Thank you so much.